a lot of patients will be coming to ask you about screening. Increasingly, since Angelina Jolie's bilateral breast operations, they'll be asking about genetic testing. Obviously, the crucial thing that you need to be sorted out is to make the diagnosis. But one of the things that we're keeping patients alive a long time, and they need a lot of support during their treatment, during their follow-up and later. So even though the average GP will only see one new case of cancer of the ovary a year or every other year, the fact we're keeping these patients alive so long is that you're likely to see them quite a few times. And one of the new things that's happening is that we are giving patients a lot more choice. And in my experience, that's producing probably the most emotional trauma after the initial diagnosis. And a lot of them are coming to you guys to help them make the decision. So I'm going to hopefully help you on that. And obviously there's palliative care. So just one or two things that you might not be aware of. The first thing is that cancer of the ovary is not usually cancer of the ovary. The latest data suggests it actually starts in the fallopian tube. And this is because they now can see precancerous lesions in the fallopian tube. And it also explains why most cancers of the ovary are already disseminated by the time we see them, because they've already floating in the peritoneal cavity to the ovary. And they're basically sort of, these are the sort of cell types that we see, but we're splitting patients into, most of them are high-grade serous, which are very high, relatively fast-growing tumours, and these classically have p53 mutations, but unfortunately, because they're so deranged, we don't have many molecular targets at them at the moment. There are the sort of the type 1 tumours, which are often slightly slower growing, which are the endometrioid, clear cell mucinous carcinomas, and also some of the borderlines, where there are potentially some new targets coming out, but that's some time away. So, first of all, population screening. Quite a few of your patients might have been in the UK tox trial, where they randomized there were 50,000 women who were getting regular ultrasounds, 50,000 were getting CA125 and ultrasounds if they were triggered, and then there were 100,000 controls. We know screening can pick up the cancers. What we don't know yet whether it makes people live longer. And so routinely we do not recommend screening for any for diagnosis of ovarian cancer. And in fact there was both a Swedish and an American study which actually had more deaths on a screening arm. Because if you start picking up false positives and sending people off for surgery, you're going to have the occasional death. So it's not something you run into easily. So, if we just think about prevention, well, the way to prevent it is to get pregnant a few times. Because obviously it's related to the number of ovulations you have in a life. So the fewer the ovulations, the slightly less chance of having ovarian cancer. Also, ovarian contraception, or contraception use can be slightly preventive, but obviously the main way of preventing it is to have your ovaries removed. But what's crucial is, as I've said earlier, it's not just the ovaries. You've got to have the fallopian tubes removed if you're going to have preventive surgery. And what really upsets me, and this is where you guys' counselling comes in, you've all had women in their late 40s who are having hysterectomies for benign conditions. Can you please try and persuade them to have their ovaries out at the same time? If they've had their kids, you can give them 5 years of HRT. In fact, what you might not realise is if once you've had your womb out, you can have estrogen-only HRT, just Premarin or just estrogen-only patch, And you'll overcome all the menopausal symptoms, and in fact, you actually might be saving lives by doing that, because estrogen only does not necessarily increase your risk of breast cancer or heart disease. It's the combined HRTs that are the problem. So, I mean, it's just so upsetting when you have somebody who has a hysterectomy at 45 and has stage 3 ovarian cancer 5 years later. So one of the things that people are becoming increasingly aware of is the BRCA mutation, particularly since Angelina Jolie. Now, BRCA mutation is BRCA is a DNA repair gene. So if you can't repair DNA damage, you're more likely to get cancer. And so patients who've got a mutation in that gene, either BRCA1 or BRCA2, we now realize that over 15% of women with high-grade serous ovarian cancer, which is the commonest type, actually have a BRCA mutation, and an even higher number have other defects in DNA repair. And what's nice is every cloud, or most clouds, have a silver lining. So if you've got a patient who has a BRCA mutation, we've got to make sure that they are offered both bilateral mastectomies and bilateral salpingo-oophorectomy once they've finished childbearing. But the good news, if they've actually got cancer, so if you've got somebody with a BRCA mutation who's unlucky enough to get cancer, they're more likely to live longer than somebody without a BRCA mutation, because their tumour doesn't repair DNA damage as well as somebody else's tumour, so it's more sensitive to the chemotherapy. And there are also some very exciting new drugs called PARP inhibitors, which actually affect the other pathway of DNA repair. So these cells, if they've already got a mutation, can't repair single-strand damage and then can't repair double-strand damage. They actually die naturally just with this tablet. So that's quite an exciting new drug. It's one of the things that kept up the AstraZeneca share price before Pfizer came along. Obviously, these are the list of things one's got to think about. Change in bowel habit, abdominal distension, bloating, and if they're feeling full or lost their appetite, abdominal pain, atypical urgency and or frequency. So we're all aware of that, but all these symptoms are very non-specific. You have patients coming to your surgery every day with these symptoms. So what should make you sort of actually do something about it? Well, one of the things you should do something about is if you've never seen that patient before and they come with those symptoms, because people don't sort of suddenly develop these things unless there's something wrong with them. And because irritable bowel syndrome is terribly common. But first of all, most women don't develop irritable bowel over the age of 50. Your irritable bowel patients, you've been seeing them for years, haven't you? And so if they sort of come back with another symptom, obviously the chances are it's going to be more of the same. But if you've got somebody who's never had any irritable bowel symptoms and suddenly comes in feeling bloating or their bowel frequency has changed, they're the patients you need to investigate. So ovarian cancer, we know, is a challenge to diagnose because of the non-specific nature of the symptoms. Unfortunately, most women are diagnosed with advanced disease, and unfortunately, our survival is worse in this country than many other of the highly civilized countries, and we don't know the exact reason. And I must admit, I suspect that one of the reasons is that you GPs don't have as easy access to ultrasound as many other countries in the world. And many countries in the world, actually patients have their own gynecologist and they have an ultrasound machine in their clinic, and they're getting them all the time because we don't see that many early stage disease. So what we're really after is that patients present with a single solitary lesion, hopefully a lot smaller than that, that's early stage disease. And if you present with early stage disease, we'd expect to cure 80% of those patients, completely cure. Unfortunately, the majority of the patients present with advanced disease with ascites, and there we can cure probably no more than 10 to 20%. But luckily, we are keeping them alive longer. Now, one of the ways to help the diagnosis is doing CA125. I mean, there's been nice guidelines to you, and I know the chemical pathology departments feel they're being driven mad by you guys prescribing lots of CA125s, but keep at it. But the important thing is just to be aware of a few things. First of all, if you have early stage ovarian cancer, it might well be normal. So an ultrasound is probably more reliable than CA125 for early stage. And the other thing is that it goes up with menstruation, so it's of no value in a premenopausal woman, or it's of marginal value. But if you've got somebody over who's postmenopausal, then it can be very important. But it can be elevated in other benign conditions such as endometriosis, but particularly endometriosis. Any major surgery can cause an elevation, colitis, lots of other things. But it's an important thing to bear in mind during the CA125. If it's rising, that's particularly important. And normally you wouldn't do a CA125 unless somebody has suspicious symptoms. But if you've got suspicious symptoms and elevated CA125, you've basically made the diagnosis probably. And that's when you need to get the urgent scan and then refer to the appropriate gynae oncologist. So these are the primary the tests in primary care. If you're concerned, you do a CA125. If it's elevated, you get an urgent ultrasound of the abdomen and pelvis. And obviously, if it's suggestive ovarian cancer, urgent referral. If it's in the normal range, you obviously need to assess carefully for other causes of these symptoms. And if you've got an obvious other reason, then you can deal with it or discharge the patient. But if the symptoms persist, then you obviously should be doing an ultrasound. Now, once the patient's sent to the appropriate person, they're very quickly discussed at one of our MDTs. And this is, in fact, the gynae MDT for sort of this area. I mean, this is Owen from the L&D. There's Malcolm Padrick from Watford. There's Alistair Drake from the Lister, and we all do it on a teleconference, video conference every Wednesday. So all the cases are discussed. And they have local MDTs for low-risk patients and centre MDTs for patients who almost certainly have cancer. So once we suspect somebody of having cancer, this is where the next big question comes in. If they've got early stage disease, well, hopefully they will be sent to the right surgeon. Unfortunately, sometimes people think it's benign and they get just a laparoscopic oophorectomy or even a cystectomy, and then we have to go back and do full staging. Because it's very important to know exactly where the disease is. Because for many reasons, if you really do have early stage disease, so if the surgeon has done bilateral oophorectomy, removed the omentum, done lymph node sampling, removed the uterus, and done sampling of the peritoneum in at least 4 sites, plus cytology, if they're all negative apart from the ovary, you can be confident they've got stage 1 disease and they've got a better than 85% chance of cure. But if they've not been properly staged, you've really got to then, you just don't know. The patient, first of all, doesn't know what their chance of being cured, and we don't really know the right treatment. So we often send them back for proper staging. Then the question is, do you give them chemotherapy or surveillance? Well, and this is a big question. If they've got really early stage disease, so say it's a relatively low grade tumour, which is just within the ovary, the capsule is intact, then we'll probably just watch that patient if they've had complete staging. If they've, say, quite a lot of these tumours have burst on removal because they might be a bit stuck, so they become 1C. If they are still low grade and been properly staged, one could still watch them. But increasingly now we're offering these patients chemotherapy, and that will be 6 cycles of usually carboplatin. And there have been good trials now to show that that chemotherapy will improve the chance of long-term survival by about 10%. So from 80% to 90% for this group of patients. That's the early stage. But unfortunately, early stage patients only account for about 20-25% of all the patients. So the advanced stage, the question is now, do you do primary surgery or do you do chemotherapy first, followed by interval debulking surgery? The other big question that's coming up is how radical should the surgery be? I don't know whether, have any of you heard of the term supraradical surgery? I mean, there's quite a lot in the press at the moment. I mean, there is probably only one supraradical surgeon in Greater London. That's Christina Fotopoulou at the Hammersmith Hospital. Supraradical surgery is when, as well, on top of doing the usual bilateral salpingo-oophorectomy, hysterectomy, omentectomy, they will spend up to 10, 12 hours inside that woman doing complete peritonectomy. They strip the diaphragm, they might go up to the chest. I mean, it's unbelievable surgery. And the reason, the reason that they want to do it is they want to aim for no macroscopic residual disease. So this will be the standard surgery, but supraradical surgery often means removing quite a lot of bowel, and basically the survival is, I started 5 minutes late. The survival of people who have no residual disease is that top line, and that's really why they push for that, to go for supraradical surgery. But I must admit, if you've got peritoneal studding throughout the abdominal cavity, I really have my serious doubts that spending 6, 10, 12 hours inside somebody's abdomen is going to make a difference. We're trying to push for a major randomized trial to sort this out because, I mean, surgeons can get away with hell. I mean, it's very lovely to hear the previous surgeon talking about a randomized trial, but usually the more aggressive they are, the more the sort of the flavor of the month they become. But you've got to be careful. But you can, if you give chemo first, you can shrink things down. And then this is a slide of a big trial which showed that if you had primary surgery or interval surgery, the results are exactly the same. Right, so you've done major surgery, you've given the patient chemotherapy, and I'll mention just a minute of chemotherapy, and then you've got to follow up the patient afterwards. They've hopefully gone into remission. And these are some of the facts I want you just to read through, and I'm going to ask you a question in a minute. So 80% of patients with advanced ovarian cancer will unfortunately relapse. Patients who relapse after treatment have a high chance of response to further therapy, but will eventually die, almost certainly. So when we finish the initial treatment, we've got to discuss the pros and cons of, do we treat them early when they relapse, or do we treat them late when they relapse? So when just imagine this is a CA125 curve of patients, and the CA125 falls with the initial chemotherapy, and then when they relapse, it starts going up. Now, I want you to imagine you're all women in your 50s, and you've just here, and you've got to decide, first of all, are you going to have regular CA125s during follow-up, or are you not? If you are going to have a regular CA125, do you want to know the result? And if the cancer comes back and you are somebody who's having the CA125 regularly, you'll pick it up here. If you're not having CA125 regularly, you'll pick it up when they actually develop symptoms of relapse. And we give patients lists of symptoms to look out for. Now then, when we treat them, it responds, and you can see that the patients who are having regular CA125 levels, they relapse again and they get treated again. They relapse again, get treated again. And basically they spend most of their life on chemotherapy. This lady waits till she gets symptoms and then just gets treated when she gets symptoms. Now, a few years ago, I set up a very big trial because I didn't know whether we should be treating people like this or should we be treating patients like that. And my supposition, I was very much in favour of this. And I sort of go to international meetings and people would make a bit of fun of me and because I was advocating that. And I'd get American patients being sent over to see me who in Europe and so on, and they said, oh, they were doing this. It was like almost going to Boots. They would have their CA125 done every week. And I thought that the American patients would probably end up living a month or 2 or 3 or 4 longer, but would have had an awful quality of life because they'd spent most of their life on chemo. So I set up a big trial. Now, first of all, before we go on to the trial, how many of you in the room would want to be in this arm and have regular CA125s?
150, I want to be in the BR. If I'm 80, I want to be in the BR.
How many of you would like to be in this group and not have regular CA125s? Right. Right, okay. So, anyway, so...
What's the morbidity?
the morbidity here, or every time you... Oh, the morbidity...
Because you're not on chemotherapy.
Yeah, basically, you only develop symptoms when you get to the black dot. So these women had virtually never had any symptoms of cancer. It was just being diagnosed. Pardon? Oh, the quality of the life of these women was far worse than these women. Anyway, so we set up a big trial with the Medical Research Council where we actually everybody had their CA125 done every 3 months, and the results were just sent to the Medical Research Council. And if the levels started rising, they were randomized between immediate or delayed treatment. And so, I mean, this trial took quite a long time. We put 1,442 women in, and I submitted the results to the largest cancer meeting in the world in 2009, and it was selected for the #1 abstract of the whole meeting. And so I had to stand up in front of 15,000 people to give the results. Now, what do you think the results were? Well, there was the biggest gasp of surprise in the audience when I put that slide up from 15,000 people to show there was absolutely no difference. And in fact, the women who had the earlier treatment, what was really disappointing, their next line of treatment was they were also treated earlier, so they ended up getting far more treatment in their life with absolutely no benefit and worse quality of life. So basically, I discuss this with all my patients now. I mean, obviously some women want their regular CA125s, they want it for reassurance, they might want it so they can detect lumps and have more surgery, particularly if they want super radical surgery, for life planning. But obviously it causes huge increased anxiety, a lot of extra chemo, surgery, and other reasons. So that's why I offer all my patients these 3 options: to have routine CA125. They can, quite a lot of patients of ours are in clinical trials, so they have to have them done, but they can opt not to know the results, and a lot of them do that. or no routine CA125. So just finally, just 1 or 2 moments on relapse. These are patients with advanced disease, so 80% relapse. The average time from diagnosis to relapse is about 18 months. But interestingly, now the time from relapse to death, it was 20 months, it's now gone up to 24, even 30 months. So people are living far longer from relapse to death than they were before they relapsed. And we've got all these drugs, many, many drugs, and I just want to finish off with probably, oh, where is she? My favourite patient, a 56-year-old lady who presented in March 2000 with stage 3C ovarian cancer. And you can see that this is all the treatment I have given her, and she's now the world record holder, having relapsed 22 times. And you can see, I mean, all these drugs that she's had over the time period, she's had radiotherapy, but she had a house in Spain. She spends most of her time going backwards and forwards. So I just, sorry. And she's also been in 2 clinical trials. So this is actually her CA125 curve. And what was quite fascinating are the longest remissions that this lady ever had was with a clinical trial of a vascular disrupting agent, a drug that attacks tumour blood vessels, that I was doing in 2003. And in fact, what's fascinating is my research fellow who treated the first patient with this drug in November 2008 is now head of oncology at AstraZeneca. And it'd be interesting to see if she's soon going to be a head of oncology at Pfizer. But that drug, you see, that was her longest remission with that drug. I'm actually starting a new trial with that drug next month. And this was her second longest remission with another vascular disruptive agent. But you can see how we can keep these patients going for a very long time with lots and lots of treatment. And okay, this is exceptional, but the average one of our patients now has about 6 or 7 treatments for relapse. They relapse 6 or 7 times. So you will see a lot of them. Just to finish off, I hope I've given you a bit of information about screening, genetic testing. You'll be on your toes about diagnosis, hopefully. You'll hopefully be able to give a bit more help to the patients when they come and ask you for advice. Should I have supraradical surgery? Should I just go for standard surgery? Which surgeon? I mean, whether I should have chemo, not chemo, whether I should be treated for relapse, whether I should have regular CA125s. And obviously, I mean, you're all involved in the terminal palliative care of these patients. Thank you very much.